Welcome, everyone. Today's a very important day in our nation's history, and it's a very exciting day for me personally. Um, Today is the marking of the death of Dr. Martin Luther King, whom everyone knows was an important civil rights fighter and dedicated his life to ensuring that people like me, you, and everyone here can sit at the same table. Like he stated, he wanted to be able to see his children, Black children, white children, Gentiles, and Jews, all seated at the table of quote unquote brotherly love and having um, dinner together. And that is paraphrasing, but that's really the essence of today. So it is with that we decided at Indy Hematology Education to have a conversation with a very dear friend, a very special person, and an outstanding physician, a rising star, who will be talking to us about her work in multiple myeloma. So our guest today is Dr. Joselle Cook. Dr. Cook is a myeloma researcher at the world famous Mayo Clinic, and she's the recent editor of ASH Daily News, amongst other responsibilities that she has had. She is an astute researcher, and today she'll be sharing with us work that she's doing, looking at disparities and also differences in the biology and potentially treatment options for patients with multiple myeloma. So, without much ado, Dr. Cook.
Thank you for that introduction, Dr. Virre. So I am going to just share my screen here with you now. And you should be seeing my full screen, is that correct?
Yes, yes, I see it very clear.
Okay, great. So we're going to talk about my work with MAGIC, the MAGIC screening study, which is MGUS Myeloma Awareness and Genetic Insights Campaign. So this really focuses on multiple myeloma and the precursor conditions. And as many of you know, the multiple myeloma is the most common hematologic cancer in people of African descent. People of African descent have 2 to 3 times the risk of MGUS and multiple myeloma, and furthermore, develop these conditions at a much earlier age than the white population. In addition, Black people have twice the mortality compared to white individuals, and we know some of this is access to care and socioeconomic factors, but there are still unknown biologic factors that we haven't fully explored to explain that excess risk of MGUS and multiple myeloma in people of African ancestry. So African people are extremely genetically diverse. They're actually the most genetically diverse group of people in the world. And this map here really just shows the various haplotypes, the great variation in haplotypes if you just look across Africa from west to east and from north to south. And we don't fully know how the genetic variation present in Africa impacts MGUS and myeloma incidence and how it presents. We do have some data for people from Western Africa, and I'll show you that in the subsequent slide. But we do know that we don't know enough about MGUS and myeloma in African people at large. This map here as well just shows, just focusing on the Somali population, for example, their genotype is 60% East African genes, but they also have a significant European and Asian genetic composition. And so this really is quite interesting because it's quite different from people of Western Africa, for instance. So one thing we do know is that there seems to be an enrichment of T1114 MGUS and myeloma in people of African ancestry when we look at large. This map here shows the global frequency of the RS9344 SNP. And it's really quite enriched here in the Western Horn of Africa, and here as well in the northern part of South America. And we've discovered at Mayo with Dr. Linda Bond's work that this RS9344 SNP is actually quite linked to the T1114 prevalence and could explain why we're seeing more MGUS and T1114 MGUS myeloma in people of African ancestry. This map here shows that the higher percentage of African ancestry, and this is mostly West African ancestry, the higher the probability of developing T1114 biology with respect to monoclonal gammopathies. We also know from work done at Mayo that there is increased senescence in people of African ancestry when it comes to monoclonal gammopathies. So using single-cell RNA sequencing and CyTOF, our group has shown that Black individuals do have more T cells compared to white individuals. However, these T cells have a more senescent phenotype than those of white individuals. And so the significance of this means is that the immune senescence in the Black population could potentially weaken tumor surveillance and create a permissive microenvironment to support plasma cell clonal development. And so the whole significance of this is that we really need to do more to understand why people of African ancestry are developing more MGUS and multiple myeloma. The data that I showed is just the tip of the iceberg. But what gives this work even more impetus is that we have a new FDA approval for the first time for smoldering multiple myeloma, a more advanced stage of the precursor continuum, which could be which provides a curative intent approach to precursor disease and could really pushes us to identify those at high risk for monoclonal gammopathies earlier and create that access more equitably. And we all know that the largest MGUS and myeloma screening studies have not excluded, but they're focused mostly on white individuals. And risk stratification tools are also derived from predominantly white cohorts and may not generalize across ancestries. And so this really pushes the need to increase awareness and health literacy of MGUS and multiple myeloma among people of African ancestries, and really have a more proactive approach to monitoring. And so we created the MAGIC study back in 2024. We launched in May 2024 with the funding of the Multiple Myeloma Research Foundation. And MAGIC-1, which is the first part of this study, is a genomic epidemiology study of Eastern African patients to start with. We aim to uncover the ancestral drivers of MGUS and myeloma. And this, I'm proud to say that this is the first ever community-based, education-focused screening study.
It's magic.
Yes. What I do is I screen people across Mayo Clinic, and I'm also going into the communities. Once we get consent, we draw about 30 mils of blood. Those with a negative test are informed, and also those with a positive test are informed. We do additional work to understand the ancestry. We also look for that SNP RS9344, and we're also looking for the Duffy null SNP, the Duffy null genotype rather, to understand how that contributes to MGUS myeloma. And importantly, every single person with a positive test is informed, and I reach out to each person to follow up with me in the clinic for a full 1-hour consult to discuss the significance of the finding and what follow-up would look like. And I also arrange for follow-up, long-term follow-up with their primary care if it's not feasible for them to follow up with me. I've established community partnerships over the past 2 years with different African groups, the North and South Sudanese associations and churches, the Ethiopian community through the United Way. This project was developed through a community engagement studio with community advisory boards, and I've also engaged feedback from a community scientist. So really showing here how this project was formed with the help of the community. This poster here really just shows, it shows one of the community engagement studios that Mayo helped me facilitate to get feedback from the community on this research. And it's really important to have a reciprocal relationship with the community. Like, their time is valuable, and we do compensate we do compensate individuals for their time to be part of this community engagement studio. This was one of the first outreach events actually the biggest outreach event that I had starting in May of 2025. Ensure that this is culturally appropriate. So not only am I focused on making sure it's grounded in their language, so we sent out invites in both Amharic and also English. I ensured that I had a colleague who spoke Amharic to translate for me. I invested in local communities, and I use an Ethiopian caterer to fund this event or cater for this event. And so I really wanted the community to feel comfortable when we did the education. So this was focused only on education at this event. I did another event in Wisconsin, which was held at Juneteenth last year. And we did blood draws on site. So this was my team there, and Mayo Clinic was really helpful and allowing me to get this put together. This was another event I held with the Somali community in another town in Minnesota, Mankato. I have the help of the Mayo Clinic mobile unit. This was a team that helped me do blood draws. This is a picture of the audience that I had. And actually, this is my son who I engaged in volunteer work to help me get this event going. This is another event we had just right before ASH last year. And importantly, I mentored a Sudanese high school student to help me kick this event off. This was geared towards the South Sudanese community. And so I really invested in the community, not only in time and education, but also trying to help create a pipeline of leadership and access or understanding of medicine and medical careers by investing in this high school student. You can see we're doing blood draws here on site, and then I catered, again, local cuisine to really make sure that the community felt comfortable and that they were really catered to. Just a few other snapshots. I did lunch and learn for all Eastern African interpreters at Mayo back in 2024. This is my research team here. And then the North Sudanese community actually preferred online meetings. So I had online meetings for them, and you can see what the participation is like here. And furthermore, they were so appreciative. One of them sent me an email to say, "Thank you, Dr. Cook, for this concise, beautiful presentation. Our Sudanese community is grateful to have you. Please come again." So the community really wants to get the understanding about research. What is the significance of proactive research? Why is screening important? They really do value it, and we have to go to the community. We can't expect them to come to us. So my interim results so far, having started in May 2024, we have 335 participants now. We have results for 278 of them. The prevalence that I've found for precursor conditions, one of the participants actually had smoldering myeloma, is 10.8%. Please note that the Icelandic study, which is the largest screening study we have to date, shows a prevalence of about 6%. So we see that the African communities really are demonstrating a higher prevalence of monoclonal gammopathies, and shows why we really need to focus on them. This is a picture of what the ancestry analysis looks like. I'm using a really special algorithm through the DNA Diagnostic Center, which looks at different tribal populations across Africa. So it's a really unique ancestry analysis. And ongoing, I'm looking at the RS9344 SNPs as well as the Duffy-Null genotype, and that's ongoing right now. I'm analyzing that data. Here I'm showing you here the self-reported ethnicity on my study so far. So majority Somali, followed by Ethiopian, Sudanese, and Kenyan. Magic 2 is my second initiative, and I am now looking at all populations, especially given the interest from the Hispanic community here. We've opened this up to everyone, but again, it's going to be grounded in the community. It's ancestry focused, so self-identified ancestry can only go so far, but I really think for us to individualize approaches, we need to understand this at an ancestry level, which would help us understand not only genotypic influences, but also immune evolution as well, and how that impacts the prevalence and evolution of monoclonal gammopathies. I have some initial funding for this from the Prevent Cancer Foundation. And so again, I want to show that we really need to invest in the community, not only with respect to time to educate and for outreach, but I also feel really happy to have given economic support to African-owned businesses to really demonstrate mentorship and develop a pipeline for first-generation minority high school students. And again, strengthening the knowledge of research and health conditions, proactive, not reactive approaches to health through sustained engagement within Black communities. And so, that is a tidbit of what I've been doing so far. I hope I've
Wow.
given you an understanding of what I've been doing for the past 2 years, and I'm really hoping I can get this out in the public, published by the end of this year.
All I can say is starting out is wow. And this is magic. And I'm not just saying this because of the fact that, we appreciate you and because we adore you for the work that you do. But what you've really done is to take advantage of a social circumstance and geographic circumstance. In other words, you are unique in the sense that you are the Mayo Clinic, and then you have access to persons who are first generation, or excuse me, who are native Africans that have, initial immigrants to the United States. So you have a pool of people that you could study and be able to determine genomic characteristics that could then impact your work. And you've taken the advantage of that, in addition to the fact that you are situated in a state which is predominantly Caucasian, and now you have Magic too, which is now going to bring in that population, and then you have the ability to look at African Americans who were born in America, African Americans who immigrated to America, and then white Americans either born here or immigrated to the United States, and it really creates this genomic pool for you to truly discover.
Yeah, you're completely right. I mean, it is, this is such a great opportunity. I am really excited for, what this holds for Black biology, really, because we have a pool or a biobank of different African ancestries, and we get to understand how this contributes to monoclonal gammopathies and even other medical conditions once we're finished with our initial work.
Wow. And I can see this work even potentially giving you information on maybe efficacy of different drugs in the future, maybe determinants of responses, determinants of toxicities of different agents.
I mean, this is, population-based screening. So these people hopefully will never develop multiple myeloma if they get treatment for their smoldering. But yeah, you're right. As this grows, I'll be able to add more people to this data set, and I really hope that I can really amplify this work so that it can be expanded outside of Mayo Clinic and Minnesota. And again, what I think is the most important and the most unique aspect of this work is the community-based approach. And the
Yes.
difference about this is that it takes time, and it takes time and investment, because it's not easy work going to different communities, teaching, educating. And I really take pride in that unique aspect of it.
Very good. So I got a couple of questions, right? Because as you can imagine, some people might say, well, this work is focused on Sudanese or East Africans who are in the state of Minnesota. And so this work is quote unquote not beneficial to me. And I noticed that in your presentation, quite appropriately, you talked about ancestry. You didn't talk about the social construct of race, but rather ancestry. And at least my understanding, and I'd like for you to expand on this for the audience that's out there, why understanding the ancestral background of certain diseases can be meaningful, not just for the people who are being studied, but for the entire population.
Yeah, that's a good question. Uh, this is important because diseases vary by different components. So ancestry and genomics actually is one contributor. Immune evolution and immune aspects are another part, and all of that is impacted by ancestry, not specifically self-identified race. I think people have already talked about the socioeconomic constructs and self-identified race, but I think for us to have an individualized approach to medicine, we really need to look at ancestry and how that contributes, and how can we actually leverage that to improve treatments, not just for one group of people, but for all. And then I'd like to add further to that to say, I started focusing on the Eastern African community because they were completely understudied. There's no data on them anywhere. But secondly, I've expanded this study, given that, you know, Magic 1 was proof of concept that this can be done in a small group that is technically a little bit harder to reach. I'm expanding this to all people, all races, all self-identified races, all ancestries, so to expand on this and make this more applicable at large.
Yeah, great answer. So as we move forward, um, what ways do you foresee either researchers that are out there who might be interested in working with you, or community advocates, or even organizations like ours, how do we connect with you? So, for example, as you know, we are based in Indianapolis. What if we said, Dr. Cook, how do we connect you with some of the churches here? Because I noticed that one of the ways you were able to connect with the Sudanese patients were through their places of worship, or the Ethiopian patients, or not patients, su- subjects. How do we connect with you and be able to have you access our population without having the people travel to Minnesota?
Yeah, my goal is to expand outside of Minnesota and expand to other states, because we have a lot of untapped populations, you know, across the country. I would love to form partnerships and collaborations with other groups. I can't do this work all on my own, and so it would involve, streamlining a methodology, streamlining how we develop this in partnership with the different communities, forming community advisory boards in the different locations, so that we can ensure that the community voice is heard, not at the end, but it has to be at the very, inception of the work or inception of the idea. Um, and then we would have to look for funding to expand this work, which I think is feasible through different organizations. But my goal is exactly that, to expand it outside of Minnesota and create a team so that we can do this on a bigger scale.
I love that answer. But there's something else you mentioned, and you've mentioned it a few times. These things don't come cheap. As much as I would love to pay for all of this work just because it's so exciting, I don't have the resources. So, for potential funders who are out there, you know, give them your pitch, and hopefully they'll be watching this and saying, "Gee, I need to fund this. This is important work."
This is an opportunity for funders to make a change in health at large. Now that there is an established treatment for smoldering myeloma, we don't have to wait for patients to present with end-stage myeloma, pathologic fractures, renal failure. If we discover these patients early, we can actually decrease the cost of healthcare. And so this is your opportunity to make that change by investing in Magic.
Thank you. And so I'd like to finish by having you sort of make some comments about Dr. King. Dr. King stated in 1968 that the most inhumane of all things that we could do to people is the inability to access equal medical attention or medical ability to receive medical health. So here we are. Dr. King died decades ago. And that statement that he made in 1966 is still true today. So, as we remember the life of Dr. King today, Dr. Cook, what will be your personal reflections of the life of Dr. King today?
I mean, his statement is so poignant. And as you said, it holds true today. There have been efforts to increase equitable access to care since then. And I think there have been significant strides made to increase equitable access to care. But at the same time, it also makes us realize that we still have so much more to do. And I think that comment from Dr. King should really, continue to give us the impetus and drive to continue making a change, because we've seen some change even in the last, you know, 60 years. We're going to see more change if we keep working and we keep optimistic and we keep doing what we need to do to increase equitable access to care for all individuals.
Thank you so much. And with that, it was an honor and a pleasure to introduce and have this conversation with Dr. Joselle Cook, Dr. Joselle Cook of the Mayo Clinic. Thank you so much, Dr. Cook.
You're most welcome. Thank you for having me.